Sorry, we have to do it this way, but. Okay, can you guys see all of that? Yes? Okay, so chapter 37, it's cognitive and sensory impairment in the child and the family. Okay, so cognitive impairment, that's an impairment of obviously cognition, so of their mental capacity. Okay, this is also used interchangeably with intellectual disabilities. Okay, this used to be referred to as mental retardation in the medical community. Diagnosis of a cognitive impairment or a learning disability is typically diagnosed when the family is kind of suspicious of their child being a little bit more slow than other kids with their learning. And typically they have other developmental delays as well. So classification of cognitive impairment, it results in their standardized testing that happened. So some of those can look at like dyslexia and dysgraphia and things like that. These standardized tests are typically done with a psychologist. They also test for things like ADHD and autism when they're doing these cognitive impairment tests. Mildly impaired characterizes about 85% of the population with a cognitive impairment. So the moderately impaired is going to be more or less substantial. So causes of cognitive impairment could be something that mom took while baby was in utero, whether that's an infection or, you know, alcohol or a drug of some sort. Could be some trauma. So when baby was coming down the birth canal, maybe he had or she had a lack of oxygen. Or mom was in a traumatic car accident, you know, while she was pregnant, anything like that. Metabolic or endocrine disorders can cause cognitive impairments. So if babies have hypothyroidism, that can really affect their cognitive status. Obviously, if they're not getting enough nutrition, just like anything, if kids aren't getting enough nutrition, they're going to have developmental delays, they're going to have cognitive impairment, they're not going to be growing appropriately, okay? And prematurity and low birth weight, that also is kind of predisposes them to be more likely to have cognitive impairments, okay? So in caring for a child with a cognitive impairment, obviously early intervention for the child and the family is going to be your most helpful thing that you can do. So getting those kids into a program to allow them to get some extra help is helpful. So these kids may be in like preschool earlier at age 3. They may have some other screenings that they do locally with their public health to kind of assess their cognition. They may be referred to a psychologist to kind of work with them, or a neurologist, depending on what's going on. So the key to the story is early intervention for these kids to allow these kids to promote at their optimal developmental range, okay? They also may need occupational therapy or physical therapy to promote their exercise and their play with others. Improving communication with the family and with the child. So you may have to use other means of communication with a child who has a cognitive impairment. These children need to be disciplined still, even though they do have a cognitive impairment. So it's important to talk with parents about that. Encourage them to socialize their kiddos. So have them in daycare, do preschool, something like that. So that way they're interacting and socializing with other kids their age. Talk about sexuality in these kids. A lot of times I think it seems weird or abnormal to talk about sexuality in kids who are cognitively impaired, but it is really important. First off, they're more apt to potentially be sexually abused because, you know, they have the cognitive impairment and they seem more like an easy target, which is a terrible thing to think about, but it's unfortunately the truth. And talking with parents and these children who are cognitively impaired about sexuality and making healthy choices if they decide to have relationships. Okay. And you guys, as nurses, will help with the families to adjust to future care. And obviously, you'll be caring for these children if they're hospitalized. Okay, Down syndrome. So this is a form of a cognitive impairment, okay, and a genetic disorder. So it's trisomy 21. So there's an extra chromosome on the 21st chromosome, okay. Causes are really unknown. There's likely multiple things that kind of influence kids who have Down syndrome. Age of the mother seems to increase the risk. So at age 35, if you're having a child, your risk is 1 in 350 births to have a child with Down syndrome. And then by age 40, it's 1 in 100th births to have a child with Down syndrome, which that's a pretty significant increase. Down syndrome occurs across all races and all populations. And it's the most common chromosomal abnormality. Diagnosis, so their appearance is used to diagnose. So babies with Down syndrome are usually pretty low tone, so they're kind of floppy. They don't get that, good head control and, body movements like other kids. When they're infants, they usually have a flat nasal bridge, a protruding tongue, more of a square head, and their eyes are kind of more wide set usually as well. So kids with Down syndrome, they undergo a chromosome analysis, usually a microanalysis of the chromosomes to then diagnose officially Down syndrome by looking at the chromosome 21. They are more at risk for congenital heart defects and low thyroid, so hypothyroidism, and actually leukemia as well. And those are just for genetic factor reasons based off their chromosome. So this is another picture that kind of talks about the appearance of kids with Down syndrome. Therapeutic management, obviously, if they're hospitalized, manage them for their hospitalization. These kids do tend to get more upper respiratory and lower respiratory infections because of their flat nasal bridge. It's harder for parents to suction them at home and maintain them at home when they get respiratory illnesses. So a lot of times you'll see these kids come in because they have like RSV or something like that. Obviously, if they have a congenital heart defect, they need to have that surgery to correct that. Looking at their hearing and their eyesight, and then also periodic testing to check their thyroid due to their increased risk for hypothyroidism. Supporting the family after diagnosis. A lot of times parents know in utero that these kids are going to have Down syndrome with all of the genetic testing that we do today. So it's, I would say, usually abnormal for parents to not know that their child's going to have Down syndrome when the baby's born, but not totally unheard of. Trying to keep these kids active and socialized and all of that, just like any kiddo with a cognitive impairment is important. And like I said, a lot of times this is diagnosed prenatally. Fragile X syndrome. So this is the second most common genetic cause of cognitive impairment. So this is more common in boys versus girls. It's caused by an abnormal gene on the lower end of the long arm of the X chromosome. Okay. So if that gene is affected, then every male will be affected with Fragile X syndrome. Okay. They have a large head circumference, long face, and a more prominent jaw, so prognathism. Large protruding ears, so their ears stick out. After they go through puberty, they're going to have large testicles. And then there's variable manifestations in the female carriers of genes. Okay. So there's a variation on cognitive impairment in kids with Fragile X, depending on how affected they are. They could have a very minimal cognitive impairment to very severe. So they're also going to have delayed speech. They're going to be more likely to have behaviors. So they may kind of mimic or look similar to somebody who has autism or ADHD. And these kids, because they struggle with communicating their basic needs, you'll start to see potentially them having more aggressive behaviors with others. So Tegretol or Prozac, I mean, that is for if they're struggling with explosive behaviors or they're having a lot of anxiety. That can help kind of manage them socially to interact better with other kids their age. If they're having a lot of hyperactivity or ADHD type symptoms, they may need to be on a stimulant. Like I said earlier, with Down syndrome or with any cognitive impairment, they need to be referred very early on to an early intervention program. That's usually through public health in most states. These kids have a normal life expectancy, but they do need genetic counseling because of the potential of, you know, passing this on to their own children. Hearing impairment, so this can occur, it's actually probably more common than you'd think, 1 to 6 per 1,000 full-term healthy infants, and then every 2 of 4 per 100 premature infants. So it's more common in prematurity. And it can be a slight hearing impairment to moderately severe. If it's moderately severe, then these kids are going to have a hearing aid fairly early on. And then obviously if it's profound hearing loss, even with a hearing aid, it's going to be hard for them to process language and be able to speak for themselves as well. There can be anatomic malformation. So actually within the ear and the eardrum, there's, an abnormality or something is not fully developed in utero. There can be a family history of hearing impairment that predisposes them to having hearing impairment. Ototoxic drugs, maybe while mom was pregnant, she was given something that can affect their hearing and damage their hearing, or too high of oxygen administration. That's when you see it, why you see it more often in prematurity because of their oxygen demands that they're having, or if baby has lack of oxygen, during the birthing process, that can cause it, or infections in utero. Kids who have cerebral palsy are also more likely to have hearing impairments. So conductive hearing loss is an issue with the middle eardrum, okay? So back behind the eardrum in the middle ear. Sensory neural hearing loss is damage to the inner ear or the actual auditory nerve, okay? And then there can be mixed conductive and sensory neural loss, which is, damage then in the middle ear and also the inner ear, as well as the auditory nerve. Okay. So you as a nurse, you'll probably be measuring kids' hearing. There's different ways to do it. A lot of times too, these kids have it completed at school. So if you're a school nurse, you're really going to be looking at kids' hearing. It's measured in decibels, which is looking at how loud that sound should be. And then it also then is measured at different frequencies, okay? Obviously, there's a threshold for hearing that's in place that then affects speech. If they're not able to hear at a certain frequency or a certain decibel, then they're going to struggle with their speech piece. Adding speech therapy, hearing implant or cochlear implants or hearing aids, other surgical interventions. So like I said, if these kids have chronic ear fluid, then, they may need ear tubes in place before their hearing impairment improves. Manifestations in infancy of hearing impairment. So they do not have that startle reflex. They do not react to stimuli, so loud noises in their environment. They're just kind of not reacting to anything. They are not making syllables or forming words by the age of 11 months. Okay. They just seem to not be bothered by noise, or they have a lack of response to spoken words. So parents are trying to talk to them and they're just kind of sitting there staring at them, not really interacting. Okay. So in hearing impaired children who are hospitalized, you guys will want to obviously provide them with more visual or tactile media to be able to communicate with them. So picture boards with common words. Use the child life specialist. That is a person who specializes in interacting with kids through play and through other means, typically play though. But you can utilize them to work with you as the nurse and the child and the family on different communication devices. Okay. Obviously, preventative measures for trying to prevent hearing impairment, like I said, management and treatment of otitis media or recurrent ear infections. If there's a significant family history of hearing impairment and mom is pregnant, then there is some genetic testing that you can do to try to help figure out if that child is more likely to have a hearing impairment. Obviously, avoiding those ototoxic drugs while pregnant, and then testing for certain infections, so syphilis, rubella, or blood incompatibility. All of those things can increase baby's risk for hearing impairment. So checking to make sure that those things are not a factor. And then obviously avoiding exposure to a lot of loud noises like fireworks, racing vehicles, concerts, loud football games, things like that. So trying to avoid those or using hearing protection. Visual impairment, this is a common problem in childhood. Usually 30 to 64 per 100,000 has serious visual impairment or blindness. About 5 to 10% of all preschoolers have some sort of visual impairment, and that's identified through like screening with a Snellen chart, or now they have little cameras that kind of look and they do little measurements of the eyes to see if it seems that they have some sort of visual impairment. And then they can take that form to an eye doctor and they can kind of diagnose if they need some glasses. Partially sighted or school vision, that's an acuity of 20/70 to 20/200. So this is, school vision, so they can see far away. If it's above 20/200, then they are determined legally blind. Okay, So these kids will need glasses for sure. Okay. So farsighted is you can see far away. Okay. Or you can't, excuse me, you cannot see far away. And nearsighted is you can see up close, or you cannot see up close. Sorry, I totally flipped those around. Farsighted is you can see far away. And nearsighted is you can see far away and you cannot see up close. Okay. And farsighted is you can see up close but not far away. Okay. So pre and postnatal infections can cause visual impairments. ROP or retinopathy of prematurity. This happens commonly in babies who are premature. The abnormal vessel growth happens. So you can see, so they have some abnormal blood vessel growth in the eye when they're born prematurely, then relates to ROP or retinopathy of prematurity, which then these kids need to have glasses because otherwise they will not be able to see. Trauma, obviously a trauma to the eye. And then sickle cell disease, JRA or juvenile rheumatoid arthritis or Tay-Sachs disease, all of these will cause visual impairments. JRA, it's usually after they've had the arthritis for a while before they start having visual impairments. But a lot of times JRA isn't diagnosed until these kids have had it for quite a period of time. So a lot of times when it's diagnosed, you will see these kids get glasses. Snellen chart, we kind of already talked about this a little bit. So these kids are going to stand 20 feet away. They're going to do one eye at a time, cover and read, and then both together. So 20 over 100 or 20 out of 100 means that they can see at 20 feet what others can see at 100 feet. And perfect vision is 20/20. Okay, myopia is nearsightedness. This is the most common issue of the eye. Hyperopia is farsightedness, so they see better, far better than they do up close. And nearsightedness, they see well close and have a hard time seeing far away. It's kind of the opposite of what you would think. Okay. Strabismus is cross-eyed, so there's estrophia where both eyes cross in. There's extrophia. So EXOTRPIA with one eye drifting usually out to the ear. Hypotrophia, this is going to be kind of a gaze down to the left. And then hypertrophia is the eye is going to wander up. Okay. Amblyopia is a lazy eye. So this is one eye and it's usually going in towards the nose. So all of these visual impairments would need glasses to help correct. So like I said, obviously trauma also can be a cause of visual impairment. So any sharp objects, blunt objects, motor vehicle accidents, a laceration or blow to the head, burns, those can all potentially cause visual impairment. And obviously preventing further damage is the goal with any kid with visual impairment, but especially with trauma. Infections, conjunctivitis, so this is also known as pink eye. This is treated with antibiotic eye drops. If it's really significant, then sometimes systemic oral antibiotics are used. You do not want to use steroids because if it's a viral cause of the conjunctivitis versus bacterial, it's going to worsen the sensitivity of the eye and the redness. Okay. Making sure that parents, when they're putting these eye drops in, they're washing their hands before and after applying the eye drops, and also that the child is frequently washing their hands because it's pretty infectious, especially the bacterial type. So they're going to have a yellow, goopy, gunky eye. Usually they wake up with it. Parents will wipe it clean, and then within about 5 to 10 minutes later, it's getting goopy again. Sometimes it's swollen and irritated and red enough that kids can't really open their eye. If there is, so you can use either drops or an ointment. So if you use the ointment, then their vision will get more blurry because it's so gunky. So it's good to give kids the heads up that that's going to happen, because otherwise they get scared. So managing a child with visual impairment. So your nursing assessment, obviously you're going to have to walk them through exactly what you're doing. They may, be blind and not be able to see what you're doing at all. So it's good to let them know before you're going to touch them, or before you're going to do anything, and just kind of talk them through the process. Obviously, if you're a school nurse or you're in a clinic or anywhere like that, you're going to be screening all children for their visual acuity using that Snellen chart. They do make a Snellen chart that has not only letters, but they also have one that have shapes on there, so they can say the shapes if they struggle with their letters. Infancy, you can kind of pick up potentially that they're having visual impairments because of a lack of eye contact or strabismus, so they have that eye drift. Now, it's normal to have some sort of eye drift or eye crossing in infants until about 4 months of age, just because those muscles, those interocular muscles, aren't fully developed until about 4 months of age. So I always let parents know it's totally okay if their kids are going kind of cross-eyed or seeming like they have a lazy eye until about 4 months. But if it's continuing after, then they need to see an eye doctor. In childhood, signs and symptoms of visual impairment, you're going to see these kids, maybe they're playing sports and they're, not catching the ball or not hitting the ball or getting hit with the ball. Running into things, just seeming really clumsy, then it would be a good idea to have them seen by an eye doctor. Okay. And then you should suspect a visual impairment in any child of any age whose pupils do not react to light. Okay. So visual impairment, so promote child-parent interaction. You're going to want to promote their optimal development, just like you do with any kid with an impairment, whether it's visual or hearing or cognitive impairment. You want them to play and socialize. If they are blind, then obviously Braille can be something that's utilized, or audiobooks or other audio learning materials to kind of help them with their schoolwork. Making sure that that child's in a safe environment and that they're getting, you're reassuring them while you're doing all of your assessments and things. You want to also orient this child to their exam room or to their hospital room, because that's a new environment for them, that they're not so aware of all of their surroundings and things that they could potentially, be tripping over. Encourage independence, and then across the treatment teams and all members involved in their health care, making sure that they're consistent with reassuring and explaining everything that's going on to these kids with visual impairments. Preventative measures, rubella immunizations for all children. That's one way. Also, moms should have be rubella immune before they have babies, because rubella is a common one that causes visual impairments if moms get exposed to rubella in utero. And then periodic eye screening for all children, and then obviously trying to prevent injuries to the eye. Hearing and visual impairment, this obviously both have profound effects on their development. Their motor skills are usually okay, but their speech and spelling and all of writing and all of that, that's visual, that's going to obviously be affected. Okay. So trying to work with them on some goals that they can achieve, usually with occupational therapy and speech, would be very helpful for these kids with hearing and visual impairments. Retinoblastomas, so this is the most common congenital tumor of the eye. So it's an interocular tumor, and you can see that right there. So that's actually, you're seeing the tumor. So when you do the red light reflex, instead of seeing a red light reflex, you see this. This is called a cat's eye reflex. So you actually see the tumor within the eye. So you can kind of see that in these kids. About 11 cases per million children a year, and it's usually kids younger than age 5, and it's usually inherited or from a genetic component. Okay, ASD or autism spectrum disorders. This is a complex neurodevelopmental disorder, usually intellectual and social effects. There's a huge, it's called a spectrum because there's a huge spectrum. Some kids with autism are nonverbal, aggressive kids that really struggle, and some kids just have, some social struggles. So there's a big difference in these kids with autism. So these kids a lot of times have repetitive, restrictive behavior patterns. If their routine is changed, it's a terrible day, like it's horrible, especially if they're not warned that their routine is going to be changing. A lot of times they have a hard time making friends. They don't really make eye contact. They may have some sensory struggles, so they may be scared of loud noises. Things like the vacuum cleaner in the home bother them, sirens, things like that. These kids may also have sensory things with food, certain foods that they won't eat because of the texture, or certain clothes that they won't wear because of the texture. And they usually have obsessions. So they get really fixated on something, and it's really hard for them to get off of it. Some of them really like numbers, and that's kind of their fixation. It's fairly common, 1 per 150 children typically. It's more common in boys by 4 times than girls. Also, some of that may be that girls kind of present differently than boys do with autism. Usually girls don't. They're usually more perfectionist, and the social piece isn't as much of a struggle, it seems like, for girls. These kids can be aggressive potentially because it's hard for them to communicate and know how to interact with others socially. There's multiple different causes. There's not really a specific known cause yet for autism. We believe it's a genetic condition, and that, there's different environmental factors and or immune system factors that can predispose kids genetically to have autism. And then if one child in a family has autism, it's more likely that another child in the family will also have autism. So clearly that tells you there's some sort of genetic component. We're just not exactly sure what it is specifically yet. So diagnosis, it's usually not diagnosed until age 2 or 3. However, the earlier you diagnose, the better for these kids, because you can try to get them caught up socially and developmentally the earlier you intervene. It's diagnosed, or should be diagnosed, by a psychologist, a pediatric psychologist. They usually do some observation and some testing and talking with parents to be able to diagnose autism. Management of autism, it can be improved or overcome, but obviously there's no cure for autism, so that child's always going to have autism. but you can definitely see varying effects. So if that child's in a good supportive home, that they've gotten early therapies in place, like ABA therapy, applied behavioral analysis therapy, which is the common treatment, I guess, or management for autism. If they have that in place early, then it seems that these kids do better. Okay. The goal of the ABA therapy is to decrease unacceptable behaviors and increase those structured interactions with other students and people. So support for family members. There are different support groups. The Autism Society of America is a good resource for information on autism. Family counseling, so family therapy. Kids with autism are sometimes very difficult to parent, and it's really difficult if you have another kiddo that maybe doesn't understand autism, so family therapy is really helpful. Parents a lot of times have guilt and shame. They blame themselves for their kiddo having autism, so therapy for parents themselves, separate from the child, is also helpful. Some parents can manage these kids at home, and some have to be placed in a long-term facility if they're really affected. Okay, here's a question. The nurse is discussing sexuality with the parents of an adolescent girl with a moderate cognitive impairment. What should the nurse consider when dealing with the issue? Which one?
C.
C. Is that what you said?
Mm-hmm.
Yep. Good. Yeah, so you have to educate people with cognitive impairments, just like you would with any kiddo, but you really have to be specific with these kids as well. Okay, chapter 38. So family-centered care of a child who is in the hospital. So obviously the hospital is a very scary place for these kids. It's scary for adults, but it's even more scary for children. They are going to have separation anxiety, most likely, because parents aren't going to be able to be there potentially for their whole hospitalizations, especially if this kid is a kiddo that's sick a lot. So separation anxiety has 3 different parts. The first phase is the protest phase. So this is where the child's crying, screaming, clinging to the parent, won't let them go, trying anything that they can to get them to stay there. The despair phase is where crying stops and they seem to be depressed. Okay. So they're not crying, they're not screaming, they're not clinging to that parent. They've stopped crying, they're kind of off by themselves. The detachment phase is when they have denial that that child or that parent is not coming. Essentially, they think that the parent is not coming back because potentially of something that they did. And then as they're sitting in that denial phase or that detachment phase, then that if the parent returns and they're in the detachment phase, then they may not interact with that parent much. They kind of almost seem to forget about the parent. Okay. So if they get to the detachment phase while they're in the hospital, then it is not uncommon for these kids to kind of have more behaviors than when their parents come back. Okay. And of course, parents are going to feel horrible if that's happening to them. Their child doesn't want to interact with them. So to reassure that the parents that that's a fairly common thing that happens when the child's hospitalized, and once they leave the hospital, that should resolve. Okay. Obviously, to manage the separation anxiety, if separation can be avoided, then obviously that's the best thing to try to do. In later childhood and adolescence, family's not quite as important as peers. So if family cannot be there, but they can interact with their peers through their phone, FaceTime, things like that, then You seem to notice less separation anxiety with parents. These kids are obviously going through a loss of control being hospitalized, so it's hard for them to not feel overwhelmed by being hospitalized and all of the effects. So ensuring that they have some coping skills to kind of help them adjust to this period of separation anxiety while they're hospitalized. Okay. The effects of hospitalization can be seen even after discharge or, as they're in the ER getting ready to be hospitalized. So you can start to see the separation anxiety piece start, or these kids start to be more withdrawn or seem more sad or scared. The child may also perceive that the illness is more, significant than what it truly is. And depending on their level of maturity, you may need to kind of walk through what their hospitalization is gonna look like potentially to kind of ease some of their anxiety. Okay. And obviously, the more hospitalizations that they have, the more likely that they're going to kind of know what's going on, and they may have a better hospitalization during that period. They may not be quite as affected, but they may also be extremely affected even if they've had a bunch of hospitalizations previously. Individual risk factors for having difficulty with hospitalization. So kids who have that difficult, defiant temperament. So they have a really hard time with transitions. They have really hard time with change. These kids are going to be more difficult to manage when they're hospitalized. You're going to have to work a lot harder with them to get them kind of adjusted or adapted to the hospitalization. Age, especially younger kids, so 6 months to 5 years, this is going to be more likely that they have that struggle with the separation anxiety. Kids who are male, if kids have cognitive impairments or below average intelligence, they're going to have more risk factors for having complications with their hospitalization, okay, or frequent hospitalizations. So changes in the pediatric population. So with peds and all of us becoming more overweight and more obese, we're getting to see more of those adult kind of serious complex problems in the pediatric population. There are obviously severe traumatic injuries that happen to children. So you're going to see those sort of procedures and surgeries potentially with those traumatic instances. With these patients becoming more complex or having more serious problems, the length of hospitalization is also increasing. So, some kids used to just go to the hospital for a day or two, get discharged, stayed home, no further issues. But now it's seeming that they're having, a lot more complications potentially because of the complexity of their healthcare. Beneficial things that you can do while a child's hospitalized that can actually benefit them. So obviously the recovery from the illness or the reason that they're hospitalized is improving. They're learning competence in how to cope with their hospitalization and cope with, stressors. So that's good. They're also socializing with other kids while they're hospitalized, typically, unless they're in an isolation room or something. But that's good that they're in different social experiences. They're interacting with you, somebody who they don't know. And obviously using appropriate nursing strategies and interacting with these kids who are in the hospital and also their parents. You're going to have to get creative sometimes with these kids who are hospitalized on how you're interacting with them. So play is probably the best thing to help you kind of explain some of the things that might be happening while they're hospitalized. So obviously it's a big stressor to have a kiddo in the hospital. So families, they can interact different ways. They overall just feel helpless. They can't help their child. And they'll maybe question staff or question the ability of staff. They may have a hard time accepting that that child needs hospitalized. They're going to be dealing with fear and kind of the uncertainty, and they're going to be seeking reassurance. So they're going to want you as the nurse to provide them with reassurance that their child's going to be okay and that we're going to do everything we can to help them recover and go back to their, typical lives, not in the hospital. So as a pediatric nurse, your patient is not only the child, but also the family too. Siblings also can be, it can be pretty traumatic for them to see their other siblings in the hospital. They may also be having to stay at home and their parents aren't there to care for them. So they're getting cared for by another, family member or friend. So that also affects the siblings in kind of a negative way potentially, or worrying about their brother or sister being ill and hospitalized, and then favoritism with the sick child, or them feeling like the sick child's getting more attention than they are. Those are kind of some things that you can see go on with siblings, or kind of questioning, they don't understand what's going on, while they're there in the hospital, wondering what all the tubes and things are. Preparing the child for admission. So this is going to start in the ER or the clinic, wherever they are, prior to their admission. So trying to reduce the anxiety, okay? Let them know what's going to be happening, who you are, all of that. That will help lessen their anxiety. The more you communicate with that child and that family, the better. Obviously, the more you communicate with them, the better your trust is going to be built as well. Okay. So minimizing separation from parents, okay, minimizing their loss of control. So give these kids some choice. So give them some ability to move around the room if they're hooked up to an IV, unplug the IV pole, let them walk around if they're capable. Let them pick a movie, let them watch a show, try to maintain their routine, and then try to maintain their independence or their industriousness, okay? So you can set out a schedule like this. This is always helpful for parents and the child to kind of have an idea of how their day is going to look. This definitely reduces anxiety. Nursing intervention, so preparing or minimizing separation. We've kind of already talked about all of this. Parental absence during infant hospitalization can be really an issue because of the need to bond with that infant. And, if they're hospitalized and parents can't be there, then that bonding is really gonna be affected, okay? And then obviously minimizing their fear of bodily injury. These kids are gonna think anytime you're doing anything, you're gonna poke them with something sharp, or mess with their IV or give them yucky medicine. So trying to work with them on minimizing their fear. Okay. Distraction things, expressive activities, so letting them paint or draw or distract themselves by playing a game or toy. This is where the child life specialist comes in, to try to provide them with the developmentally appropriate activities while they're hospitalized, kind of distract them from what's going on. Okay. Okay, do you guys want to keep going?
No.
No?
I'm tired.
I don't blame you. You guys here. You disappeared on me. If anyone wants to keep going, we can keep going. But otherwise, I understand you guys had an exam. I know you guys have other exams too, so I understand. Plus, Cahoots didn't work like we wanted it to. But if you guys want to leave, you can leave. But if you want to sit and we can keep talking, we can.
Thank you. You have a good night, ma'am.
Yeah, you guys too.
It don't matter to me.
Are you guys staying on? No, getting off.
Is everybody leaving? It didn't matter to me. But I guess if everybody leaving, then that's fine.
I think there's just a couple of you guys left. So we can keep going if you want. I just have to be to daycare by a certain time. So we can keep going for the next 5 or 10 minutes here.
Okay, that's fine.
Okay. Let me pull this back up. Okay. So nursing care of the family, obviously, like I've said, supporting the family members is going to be a big part of what you're doing while the child is admitted, and then preparing the parents for discharge and any home care that they may have to do. You know, these kids might have crutches, they might have to be in a wheelchair, they might have you know, other sort of things that parents have to work with, that they might need to figure out how to give them medicine multiple times a day. So you as the nurse will help give those family members kind of tips and tricks on what to do. The other thing as a nurse, like I said, if these kids go through the stages of separation anxiety and they're in that detachment phase, you will need to kind of foster that parent-child and interaction and that parent-child relationship. So get the parents involved, reassure the child again that, you know, they're not going to be left in the hospital forever. And that, you know, eventually they will go home with the parent when they are, you know, healed up. And then obviously educating them on anything that they need educated on. Ambulatory outpatient setting. So this is more of a clinic setting. So this is, you know, going to increase cost savings. So instead of having them be admitted, if you can follow them in a clinic and, you know, have them come in every day in the clinic, that would be better usually as far as costs for the family. It also reduces their chance of infections. Obviously, if we're in the hospital, we're getting exposed to a lot of hospital germs that if we're in an outpatient setting or like a clinic, we're not going to get exposed to as many of those hospital kind of germs. And it's also less stressful because parents don't have to worry about their child being, you know, in the hospital and admitted to the hospital. So if you can follow kids in a clinic setting just more often, that's better for the child and the family. Isolation. So obviously if these kids are in isolation because of one of their diagnoses, they're going to seem more isolated because they can't interact with the other kids on the unit while they're admitted. So these kids will need more toys or activities from child life to help prevent, you know, them having developmental delays or kind of becoming behind because they're not interacting and socializing with others like they typically do. Emergency admission. So this is the most traumatic of hospitalizations, to go through the emergency room and have it be a true emergency. Obviously, parents don't have much time to try and plan or to gather their things when their child's being taken to the emergency room urgently. So this seems to be the most traumatic form of a hospitalization. There is obviously overuse of emergency departments across the US. So people taking their kiddos in for ear infections or sore throats, things like that, that puts another kind of stressor on the emergency department for when actual true, cardiac arrest, things like that come into the ER. And then the participation of the child and the family in the environment is going to be helpful in any case, but especially in the emergency department. If that child is able to interact and make decisions about their care, that would be the best thing to do. ICUs or intensive care units, so the PICU or the NICU, these are very, very stressful for parents to have their kids admitted to both of these floors. You as the nurse will need to be meeting these parents and these children's needs emotionally. Parents are going to be really confused about all the lines and tubes and things, so you're going to have to explain all of that to them to kind of ease their mind. And then that critically ill child becomes the sole focus of that parent's life. So the parent may forget to, care for themselves, eat, drink, things, brush their teeth, change their clothes, things like that. So you as the nurse, a lot of times will have to be the advocate for not only your patient, but those parents to be able to take care of themselves, so that way they can take care of their ill child as well. That's probably the most common thing you see is parents not eating or drinking for a while because they want to not leave their baby. Okay, question. During the first 4 days of hospitalization, Eric is 18 months. He cried inconsolably when his parents left him. Then he refused the staff's attention. Now the nurse observes Eric. He appears to be settled in and unconcerned about seeing his parents. The nurse should interpret this as which of the following?
C.
C?
C.
Yep, C. Yep. He's experiencing detachment, right? He's gone through the stages of separation anxiety, and that's where he's at. So as the nurse, it would be best for you to kind of, the parents, like I said, are going to feel really poorly about this happening. They're going to feel terrible that their kiddo does not want them there, just seems to kind of ignore them. So to reassure them that this is a pretty normal part of a hospitalization, that it's nothing that they did, parents will really need to hear that during that time period and be supported. Okay, I think that's probably a good spot to stop. The nursing interventions, you guys have this PowerPoint, so you should be able to see it. Read through it. Make sure you've read your all your chapters. Okay.
I don't have that kind. Is it the same setup? It's just different.
What was that? I'm sorry.
Is it the same setup? It's just different, like pictures or something. I don't have that slide. Like it doesn't look like yours. Or is that one? Mm-mm. It looks like this. Show you.
Okay.
They look like this.
Yours looks like that.
Mm-hmm.
Oh, is it just because you haven't downloaded the? That's what's in the announcements?
Yeah, that's like in the in the module for week 4 when you go to the readings and then you click on them, they all look like that.
Oh, well, that would be your, is that your book?
No, this is a PowerPoint. Like
Huh.
it goes with yours, just don't look like it. But is it the same? I'm not sure.
It should be the same.
Okay.
In the information post, like for week 4 information, that's where this PowerPoint is posted.
Oh, okay.
So if you go into the announcements, that's where I'll post my specific PowerPoints.
Yeah. Okay, I see it. Thank you so much.
Yep, you're welcome. I think that they do have some information linked under the in the modules, but for the specific PowerPoints, those are going to be in the
Announcement.
announcements. Yep.
Okay, thank you.
Yep. And with any other handouts that you guys might need.
All right. Thank you so much.
Yep. You're welcome.
Bye-bye.
Yep. Bye.
I just have a question really fast.
Yeah. Sorry, Patty. You've been like flipped all around, haven't you?
No, I have been, but that's okay. I think we're way closer to having this figured out. So
Yes,
Thursday, Thursday, my exam. Do you just want me to
Yes.
log back into the Zoom at 9?
Yep. Yep.
Okay.
Yeah. Log in a little sooner than 9, just so that way I can get you and the other student all set up.
Okay.
And checked in. So like 10 or so minutes before 9 would be great.
Okay.
And it's 9 Eastern. So if you're Central Time, then 8 p.m. Central Time.
Nope, I'm pretty sure I've looked enough and I'm
You're Eastern Time. Okay.
yeah.
Okay. Yep. So 9 Eastern on Thursday, and just make sure you have your ID, your 2 devices. So your computer to take the exam on, and then your phone or what have you to do your camera.
Okay.
And then a whiteboard or a piece of paper, a blank piece of paper. Okay.
Gotcha. So I can use the paper. Like I was really confused about that. Why that was ever a huge problem.
Yeah. So as far as I have been told, the paper is okay. I mean, I didn't teach last term, so I guess if they talked about that last term and it just hasn't been updated in the policy yet, then it's okay.
And
Like paper,
honestly, it
What?
was just one of those that were just thrown at us. Like, oh, by the way.
no paper. Okay. Well, I haven't heard anything about it, and I've been allowing
good.
students to still do that. So I guess if I get told differently, then that will have to change. But if it's a purely blank sheet of paper, you show me the front and the back, then I will allow that.
Okay. I mean, I have a whiteboard. I was just curious. Like, do I
Yeah.
have to use it or?
Yeah. I mean, I would prefer probably that you use a whiteboard, just because then you can erase everything after. But the paper, I mean, people have utilized those for me and it's been no issue. So
Gotcha. Okay. All right. That sounds good.
Yep. I'll see you later.
All right. Thanks.
Bye.
Bye.